Hello, uh, good morning everyone. Myself Dr. Marathi, and now I'm going to discuss about the fungal prophylaxis in the NICU. Before going to the in detail, in this topic, we're going to discuss about the what is the incidence of fungal sepsis in the NICU, and what are the risk factors for fungal sepsis, and what are the medications, what are the antifungal agents that are used for fungal prophylaxis, and what is the evidence and other things we'll discuss. Coming to introduction, fungal sepsis is the third most common cause of late onset sepsis, and coagulation negative staph aureus and the staphylococcus aureus are the two most common agents that are causing the late onset sepsis other than fungal infection. And in fungal infection, Candida albicans is the most common organism that can cause late onset sepsis. And invasive candidiasis may cause death or neurodevelopmental impairment in almost 75% of the infected ELBW infants. And incidence of invasive candidal infections in various NICUs, the incidence varies between the various NICUs, and the most likely this difference in the incidence is maybe due to difference in the patient demographics and the difference in the resuscitation and feeding practices and infection control practices and the antimicrobial use. And incidence also varies among the countries and varies among the NICUs. In USA, the National Nosocomial Surveillance System that was conducted between 1995 to 2004, and that was including around 132 NICUs, showing the incidence of invasive candidal infection is around 5 to 5.07%. And the rate also varied among the nations of the USA, and it was ranging from 3 to 23%. Similarly, in another review that was conducted by Parikh et al. In 2007, that was showing the incidence of 2.2 to 12.9% in VLBW infants and 5.5 to 16.5 in ELBW infants. The study from North India shows the incidence of invasive candidal infection is of around 22.8% in preterm staying more than 1 week in NICU. And among invasive candidal infections, endocarditis forms around 15.3% and 8.4% babies had meningitis. And the mortality rate also varies among the gestational age and the weight of the baby, and it is highest for babies who have weight less than 750 gram, that is around 47%, and other babies with 1000 gram have around 38% mortality rates, and babies with 1500 gram have around 32% of mortality rates. And the mortality rates following candida infections also varies among the which species of the candida is infecting. And the most common organism is Candida albicans, and the mortality is highest for this organism. Coming to the risk factors for candida infections, lower birth weight and gestational age are the most significant risk factors. Other risk factors that are like endotracheal intubation, mechanical ventilation, central venous catheter placement, parenteral nutrition, and medications like corticosteroids, H2 blockers, broad spectrum antibiotics like third generation cephalosporins and carbapenems. And other than this, late onset bacterial sepsis and gastrointestinal disease are the independent risk factors for invasive candidal infection. So, coming to the prophylactic strategies, like to prevent, what are the preventive measures that can use to prevent the fungal sepsis? In the last decade, the strategies to prevent invasive candidal infections are mainly focused on adherence to the optimal infection control policies and avoidance of unnecessary broad-spectrum antimicrobial use, the prompt removal of the infected devices. And nowadays, the availability of the many antifungal agents, we can also use antifungal prophylaxis. The main motto of antifungal prophylaxis is we have to give the antifungal agent before the colonization of the Candida infection. It usually occurs in the first few postnatal weeks because prior to colonization is a prerequisite for development of invasive Candida infection, and prevention of the colonization has been proposed as a possible preventive strategy. So next question is, who should disuse the antifungal prophylaxis? There are various studies, various randomized controls that have studied this antifungal prophylaxis, and various studies have different criteria for the starting fungal prophylaxis. The most commonly used criteria was specific birth weight with or without the specific gestational age. And other criteria are presence of central venous catheters, the history of candida colonization, prior antibiotic use, and the presence of abdominal surgery or disease. And other criteria mainly depends on the risk factors. Coming to the babies with less than 1000 gram, they have the higher rates of invasive candle infections, and also they have the higher risk for poor outcome associated with candle infection like neurodevelopmental defect and immediate complications. Similarly, the babies with birth weight of 1000 to 1500 gram, they also have the higher risk of invasive candle infection, but risk is less compared to the babies with less than 1000 gram birth weight. Similarly, the candida-related mortality is low compared to ELBW infants, but invasive candida infection is also can cause potential morbidities like severe illness, prolongation of the hospital stay, and long-term neurodevelopmental impairment can also occur. Hence, the babies with birth weight of 1000 to 1500 gram, it's better we should go with risk factor based approach whether to start or not. The 2006 Red Book of the American Academy of Pediatrics recommends considering the fluconazole prophylaxis in ELBW infants. And there is lot of scientific sufficient data to support the use of fungal prophylaxis in ELBW infants in NICU. In NICU, whose baseline fungal rates are high. The baseline fungal rates taken as 5% in some NICUs and 10% in some NICUs. Mainly in Indian scenarios, it's better to take as 10%. In other countries, they have taken 5%. And fluconazole was the most common agent that was used. That's a 66%, followed by nystatin and amphotericin B. So coming to the next, which fungal antifungal drug it is better for fungal prophylaxis, and the most common, as I told, the most common agent that was used is fluconazole. So the question is why fluconazole? Because various advantages of the fluconazole, like in the form of pharmacological factors, immunological factors, and other less adverse effects, they made the fluconazole the first drug of choice for fungal prophylaxis. In pharmacological factors, it has a very long half-life, so the dosing can be once a day can be used, and it is well concentrated in the tissues and the body fluids. This is very important because the fluconazole will concentrate around 1.2 to 1.4 times more in the mucosa compared to the plasma. Similarly, in the skin, it is around 10 to 40 times more in the skin compared to plasma. And fluconazole has 70 to 90% CSF penetration, so it also helps in prevention of the CNS infection. And it is up to 80% of the fluconazole is excreted unchanged in the urine. Coming to the immunological factors, it impairs the adherence of candida to endothelial and epithelial surfaces and decreases the biofilm formation in central venous catheters and enhance the killing of the candida species through direct eradication and improve the host defense response. And it has very minimal side effects. The only side effect that is bothered is reversible elevation of the liver enzymes or bilirubin without any long-term sequelae. The next thing is whether how much dose we have to give and what is the interval of giving and what is the duration and when to start and other things we'll discuss. And the dosing, the dose will vary from 3 to 6 mg per kg per day in single OD dose. And some many studies that shows 3 mg per kg, that is 50% of the minimum treatment dose, had similar efficacy compared to the 6 mg per kg in preventing invasive candidal infection. So even minimal dose is also helpful. And the interval is twice a week interval can decrease the maximum number of doses by 50% without adversely affecting the efficacy. And when to start, as I told earlier, it's better always start before fungal colonization starts because fungal colonization is the main important risk factors for invasive candida infections. So ideally, it should be start on the first postnatal day. The duration of prophylaxis, it should continue throughout the period of highest risk to the infant. So you have to continue till there is presence of risk factors. For example, intravenous catheters, parental nutrition, and broad-spectrum antibiotic use. Within these limitations, the most infants should receive usually 3 to 6 weeks. No, there are many studies like randomized control studies, retrospective control studies. There is lot of evidence to support the fluconazole prophylaxis. Among them, the Kaufman et al. Study that was conducted in 2001. It was included ALBW babies with birth age of less than 5 days, and it was a single center placebo-controlled RCT with sample size of 100. And the dose of fluconazole was used was 3 mg per kg intravenously for 6 weeks. And while comparing the efficacy of fluconazole in preventing candida infection, there were no candida infection noted in prophylaxis group, and there were 20% infection in the control group. And there are no candida-related deaths in prophylaxis group, and there were 4 candida-related deaths in the control group, and it was statistically significant also. Similarly, other studies like Manjoni et al. That was conducted in 2007 with VLBW babies, and it was a multi-center placebo-controlled 3-arm study with the sample size quite significant, that is around 322, and the dose was 6 mg per kg or 3 mg per kg that was used for various birth weight babies, and there were 7 candida infection in babies who have got fluconazole prophylaxis, and they were compared like in control group there are double the risk of infection, that is around 14 of the 106 babies, not the double, it's almost 4 times, like almost 13.2% in control group, and it was 3.2% in the candida infection, and there are no candida related deaths in the prophylaxis group, and there were 2 candida related deaths in control group. Similarly, there are so many retrospective studies with historical controls showing the various uh, percentage of infection, Candida infection in controls versus in the prophylaxis groups, and also the death reports. And most of these studies also showing the significant results. On an average, there is a risk of candida infection in the control group is around 10%, and in uh, prophylactic group it is just 1 to 2%. And all these studies showing significant reports, significant results. These are the other 2 studies that are showing the evidence for fungal fluconazole prophylaxis, and one of the study also has the significant results. Coming to the safety of fungal prophylaxis, as I told, it is a metabolized by the fluconazole is metabolized by the liver, and it can cause hepatic dysfunction and cause reversible elevation of the liver enzymes and the bilirubin. However, in many studies there is no need for discontinuation of the fungal prophylaxis. And also in many studies, the noted percentage of incidence of cholestasis is around 31%. But after adjusting for confounder factors like antibiotics, H2 blockers, and hepatically metabolized medications, parental nutrition, GI pathology, after adjusting these confounders, the actual incidence is almost zero, and fluconazole was not associated with any development of cholestasis. And there is no emergence or increase in the incidence of fungal fluconazole resistance, and it was not documented by any studies. Coming to the last slide, that is conclusion. An invasive candida infection is a serious problem in ELBW and VLBW infants, can cause prolonged hospitalization, death, or neurodevelopmental impairment in most infected infants. It will cause both acute and long-term morbidities. So, fluconazole prophylaxis is safe, well tolerated in ELBW and VLBW infants, and it reduces candidal infection and candida-related deaths in infants without emergence of any resistance. Although it is a multifaceted approach to preventing invasive candidal infection, but fluconazole prophylaxis may not be appropriate in all NICUs. and it should be strongly considered in units caring for infants whose birth weights are less than 1000 gram and birth weight less than 750 gram, and infants who have significant ongoing risk factors and NICUs with baseline rate of fungal sepsis is high. Okay, thank you.